Okay, so we are live.
We are live at the moment.
Okay,
Yes. So, hello, everybody who may just be trickling in on the Institute for Creative Mindfulness Facebook page. I'm going to give us about a minute or two before we formally start, just so people can find us. So, if you're here for the noon interview today, we have quite a few live casts that we're doing today. You are in the right place. And if you want to share the interview right on your personal page, you can by using the share feature. And I'm making sure that everything's set up on our end. Wonderful. So welcome to today's noon live cast. I'm delighted to be joined by somebody I consider to be one of the leaders of the trauma field, as a writer, as a advocate, as somebody who served on boards of all these important organizations to get trauma and complex PTSD more acknowledged. And this is Dr. Christine Courtois. Welcome today.
thank you very much.
So, Dr. Chris, for people who maybe aren't familiar with your name, or for people who are only familiar with your work, but not so much about your background, can you tell us a little bit about yourself, what led you into the field, and what led you into working with trauma?
Okay, and I do like to refer to myself and my peers from those days as old war horses
Got
because
it.
we've been at it for a long time. And I'm actually not that old, of course, but I've been in the field since 1971, which is when I started grad school. And when I was immediately in grad school, I was put into situations of having been traumatized myself as a residence hall advisor and director. And we had some pretty horrible kidnapping gang rapes at the University of Maryland. And several of us we also had at that time a couple of suicides from our dormitories. One of them was mine. And so I was this brand new graduate student with no knowledge about anything like that, and no life experience. And over the course of the number of rapes that happened, that we had sort of a copycat situation, a number of us decided to get together and found a rape crisis center. The DC Rape Crisis Center had just founded. I think that was one of the first in the country. And I believe that the University of Maryland Campus Crisis Center that we developed was the first on campus. So I learned very quickly through personal experience what happened to rape victims. And there was beginning to be a literature at that time, but not a whole lot. So we didn't have a whole lot to go by. And unfortunately, we learned by the seat of our pants or by being in the trenches, which is good news, bad news, because one of the things was, for example, if you went to the emergency room with a rape victim, you could be assured that you would be there all night or all day, because the rape victim would be treated as though she were a piece of trash
Yeah.
and not given any kind of priority. So we learned about some of the injustices way back then. Um, as I went through my graduate program, I started out as an administrator in college administration, which for me would have been a disaster. So I was very lucky that I found out that I had some gift of being able to empathize with people who had been traumatized. And back then, there was not a lot of literature, and there was no PTSD diagnosis until 1980, as you know. But Vietnam was going on, the women's movement was going on, the racial injustice movement was going on at the time. Those were very heady times. And, we began to learn from each other and from the work that we were doing, from the veterans who were returning and from the rape victims. Well, in the course of, I know this is a long answer, but it encompasses a lot. In the course of doing the, the crisis center work, we had a number of younger women who were still at home who contacted us and said they were being abused and raped, not out on the street by strangers, but by family members. And so this was the beginning of the opening of looking at incest. Judy Herman had published her first book, which was Father-Daughter Rape, or Father-Daughter Incest. Um, and I followed up, and I was looking for a dissertation topic, and Lenore Walker, of all people, was on our campus, and she had just worked with battered women syndrome and developed that. And she said to me, well, if you want to know about these young women, you should interview them. So my dissertation was an interview study of women who experienced childhood incest and were willing to talk to me. And so in some ways, I became an instant expert in the topic, even though I didn't have a broad background. So that's been a little disconcerting. I certainly feel a lot more as an expert now than I did then. But it got me into the early trauma field and the development of the trauma field, including the early development of PTSD and the DSM.
Sure.
And over the course of these many years, I have found myself at times being what I call crispy fried through vicarious trauma or whatever.
Sure.
And every time I get like that, I get pulled back in with the intellectual interest that I have and the way the field has developed just enormously over time. I also have been involved in some of the controversies, as you know,
Sure.
over the course of and in some of the professional organizations. So that's really the starting point. And 10 years after the research, my dissertation research, when people kept identifying me as an expert in this area, and legitimately I did know more than a lot of other people, I wrote my first book, Healing the Incest Wound, with the expectation that nobody would want to read it. But I had a book in me, I produced it, it's a big heavy duty book, and it turned out to be a classic. And
Sure.
nobody was more surprised than me.
Right.
So I've stayed in the field since then.
Yeah, something you said about the history of your evolution that really impressed me is that you had a gift to empathize with trauma victims and trauma survivors. And I mean, I we could talk all about the controversies and the debates and labeling and treatments, yet so much of what I teach is it really comes down at the end of the day to that gift to empathize.
Right.
And
of course, now we're putting a lot more emphasis on relationship and interpersonal healing for interpersonal and relational injury.
Sure.
So, that's a foundational issue. And, my example of being in the emergency room, there are so many people who have been just plain hostile and damaging to adult survivors. That's another thing that got me going. I'm not trained as working with children. I've always worked with adults, but I was so outraged by what was happening or not happening, or the way adult survivors were being treated in the mental health system and in the medical system, that really promoted and got me to continue to work in the area as well.
Sure. So going into an area that might be touching on one of these controversies we talked about, which is diagnosis and labeling and however you may look at it. So tell us a little bit, and I know a lot of our listeners know the history, but if you can give the nutshell and maybe some perspective of what it was like to even craft the PTSD diagnosis. And then what makes complex post-traumatic stress disorder, which is really the topic of our discussion today, fundamentally different than post-traumatic stress disorder?
Well, PTSD was designed, and it was initially proposed by a group of psychiatrists and veterans. And it was based on trauma that occurred, war trauma, combat trauma. And it was based on work that was done in the 1930s, I think, also. A psychiatrist by the name of Abraham Gardner had put together the original formulation and criteria. So that's what was used along with what was happening in Vietnam to create the first PTSD diagnosis. Now, that diagnosis in and of itself was controversial because it speaks to things happening outside of the individual, influencing the individual, and not just intrapsychic. It was, as was the Freudian perspective of the time. So those of us on the ground doing this work with whatever population we were working with were really excited about the PTSD diagnosis because it fit a lot of what we were seeing. However, Judy Herman, myself, other people who were then studying childhood abuse and its consequences, David Finkelhor was one of them at the University of New Hampshire, soon took a look at it, at the consequences, and said, oops, this doesn't fit exactly. There's more to this with adult survivors of childhood trauma. And over time, of course, we've identified that as the developmental impact and made a differentiation between trauma that occurs on a personality that's largely formed, as would be the case with soldiers, versus child who whose maturation was impacted and actually whose immaturity may have been used to violate them in the first place. So, and in fact, back in my dissertation, I came up with a listing that Judy Herman put in her book. She didn't cite me because it was independent of her work. But what was very interesting is in those days we were sort of comparing and contrasting our work to find out whether we were all on the same page, and it turned out we were. So when Judy published Trauma and Recovery, and simultaneously published an article that proposed CPTSD, complex PTSD, and proposed that it be a new diagnosis within the DSM system into DSM-4. Nobody was more happy about that than I was, because it made all the sense to me. It agreed with everything I was putting together. I really liked the name. I really liked the fact that we had a formulation for it. And so I ran with it, as did many of my peers. And what we ended up politically was up against the PTSD people who were hell bent on there was only one type of PTSD. Well, I think we've really come around to know that there are many different types of PTSD.
Right.
And yes, there seems to be consistent psychophysiological responses to being traumatized, but that's apart from the developmental impact of being traumatized over the course of childhood, for being traumatized repeatedly within the context of significant caretaking relationships. So, unfortunately, the DSM-4 committee agreed to adopt CPTSD as a freestanding diagnosis using Judy's 7 criteria. And lo and behold, when the DSM-4 was published, it was not included except as an associated feature of standard or class, what's now being called classic PTSD, which was really unfortunate. And Judy writes that it was the higher up people in the DSM who made that decision, but nobody really knows where that came from. So for DSM-5, people wound up again, and there are a lot more data these days because now we have a child traumatic stress network that's been in operation for at least 10 years, and that's been looking at, and in fact, they have what's called a comprehensive data set about what happens to traumatized children and in treatment. And it's very consistent with complex PTSD, but they call it developmental trauma disorder, would be the disorder for youngsters. And both developmental trauma disorder and complex PTSD were not included in the DSM-5. My understanding is because the formulators said that there were not enough data. I would take issue with that. And I have taken issue with that.
Yes, as have I.
Yes, I think there's sufficient data. The comprehensive data set is also one of those sets that I think would be adequate. And the irony is the committee now is looking for more for the diagnosis, to the diagnosis, than was originally in the PTSD diagnosis. So it keeps getting tighter and more rigid. So you know, and probably our listeners know that complex trauma is not a freestanding diagnosis in the DSM, that PTSD or classic PTSD has been expanded in the DSM to look more like complex PTSD. They have added a dissociative subtype, which really matches a lot of our patients. So I see a lot of our patients being in that category. And they also have added a category of pre-age 6 PTSD in lieu of having a separate diagnosis for children, which I think is really needed at this point in the DSM system. So while all that was happening, and we provided information, my colleagues, some of my compatriots have been very hard at work. The ICD came up for revision, and Marilyn Courtois and her colleagues and European colleagues did significant research to identify and to start to pull down what are the different aspects of complex PTSD from classic PTSD. And their data showed that emotional regulation difficulties identity difficulties, relational difficulties, really made the distinction. And add to that, that there's much more somatization that's not included in the DSM
Right.
definition of classic trauma, classic PTSD, and there's much more dissociation, leading some people to say that if a child has been chronically abused, it's more than likely that they're going to be used dissociative defenses, if not develop a dissociative disorder. They're not the same.
Right.
It seems to be on a continuum of some sort.
Sure. Sure. So as I'm hearing you talk about the progression of these diagnoses and the controversies, a very simple question that I have for you, and I obviously have my ideas and I will teach on these when I have the time to do it, but what makes trauma so controversial? Codifying it, diagnosing it, treating it?
Well, a lot of things. I think that it's a political issue. When you're talking about trauma that occurs in the family by family members or by individuals that are either related or have a fiduciary duty, boy, we really don't like looking at that. All you have to do is go back to Freud and his formulation going out the window right away. So it's significant denial, it's significant resistance to acknowledgement. We can't believe that good people do these kinds of things or do these kinds of things to children. I think what's changed in the last, say, 20 years or maybe since 9/11 is our society understands a lot more about trauma and trauma reactions. However, they go on and make a mistake because they know about trauma, so now they assume that everybody who's traumatized gets PTSD. Is not the case at all, especially in adults. Children are more vulnerable because they're children, they're younger. But we have more acceptance, and certainly the Me Too movement, what's going on now in the streets with the racial equality movements. I mean, years ago, you couldn't talk about colonial trauma. You could not talk. I was in Australia and I mentioned colonial trauma and nearly got clobbered. And I just saw a phrase that I haven't seen before, which is post-slavery traumatic stress disorder, which has not been acknowledged, which has not been seen as real. You know, these are parts of our history or parts of our current life that are really hard to deal with.
Right.
So that's kept it in a closet, and you know, mental health professionals haven't wanted to deal with it.
Correct. I've noticed. Yes.
Yeah, and then you know, there's also when what we talk about when the trauma is distal, meaning in the distant past, most often the survivor doesn't understand there's any connection to some of the ways they live or some of the symptoms or maybe all of the symptoms that they have. And so it's only as we've been able, and they have incorporated a lot of negativity because they're often blamed for their symptoms.
Yes.
And so one of the things we need to do is first of all, make the association, but also remove the stigmatization.
How do you think we do that? I mean, what's the thing that's worked and what still needs to change with removing stigma?
I wrote a little book, and it's been surprising to me that I've gotten all kinds of response to this little book because the title is "It's Not You, It's What Happened to You."
Yeah.
And that's one of the things we have to do. We have to acknowledge what happened, but we have to say you've been impacted by it, but it isn't all of you. And it doesn't mean that you're bad or you deserved it or you're a black hole. We hear that from, and I'm sure you hear that all the time, from many adult survivors who are so ashamed and they carry the stigma around with them. And so I've gotten great response just to the title of that book.
For sure.
Because we have to make that differentiation.
Yes. So speaking of books, you have a second edition to your book that I consider a classic, Treating Complex PTSD in Adults, written with Julian Ford. And I often cite your definition of complex PTSD from that first edition, because I do find it's very compact while also being all-encompassing. So tell us what's new with the second edition.
Oh, well, I'm just going to show you the cover of the second edition. Well,
Lovely.
You can't see it very well.
Just hold it up a little bit more. Hold it up a little bit more. Yep.
Okay.
Great.
First of all, I want to reference the cover because an adult survivor provided the artwork for the cover, and we really
Beautiful.
love it. And it peps up the book cover
Hmm.
significantly. But what's new is this is a 10-year anniversary and revision of the original book, Treating
Hmm.
Complex Traumatic Stress Disorders. And you'll notice the title, Disorders with an S, because our idea is we are still learning about what the disorders are and what the consequences are to being so traumatized, and we'll continue to learn. And what we did is we took the 2009 book, and we were supposed to only add about 35% of new material. Well, there's about 75% of new material.
Sure.
So we've expanded discussion of what constitutes complex trauma in the first place and what constitutes complex trauma reactions and stress disorders. We've covered the history I just covered. And we talk about some of the foundational issues in good trauma treatment in general.
Hmm.
And as you said before we started the show, unfortunately, even to this day, many mental health professionals have no training in their curriculum, in their
Yep.
professional training. And actually, also about 10 years ago, Steve Gold and I wrote an article, um, which was the lead article for a new journal that we were working on. And the journal name is Psychological Trauma. And the title of the article was The Need for Inclusion of Trauma in the Professional Curricula,
Hmm.
a call to action. And we have had some response to that call, but there's still a massive amount of education and incorporation of traumatic experience and trauma in professional curriculum.
Sure.
Because we've also found out that the majority of mental health patients are there because they have some type of trauma history
Hmm.
in their background. So it really behooves us to look at that. And then we went on to invite authors, as we did in the first book, um, to write about different treatment strategies that they've developed or have developed over time to work with this population, and then to try to relieve some of the, you know, flatness of just reading a description.
Hmm.
We ask them to apply their particular orientation to a transcript that they
Hmm.
developed, so that we could see how it worked. So you can, it's interesting because you can see how the different ways of working with people can go after things in different ways. We also ended up consolidating this and saying that the treatment is best when it's formulated for the client and the client's needs.
Yes.
There's a variety of different options that you can use. It doesn't have to be one size fits all.
Hmm.
But we do say with our original formulation, what Judy Herman had put together so long ago, that it needs to be progressive and it needs to be founded on safety
Yes.
and skills, emotional regulation, stabilization of life circumstance in many cases, before moving into the trauma work. Now, that particular recommendation is controversial these days.
Of course.
Primarily, cognitive behavioral therapists are saying we don't need all of that preparation.
Hmm.
People who work with complex trauma are,
Hmm.
very rigid in saying, yes, we do, because we've
Oh
all
yeah.
been on the other side of, if you don't do that, you may have a
Yeah.
client decompensate right in front of
Hmm.
you.
Right.
So that's going to be an ongoing debate. And, I don't want to
Okay.
get into the polarities of that because
Right.
some complex trauma survivors can go through a treatment that doesn't have
Hmm.
a preparatory phase, particularly if they have a good attachment background and good
Hmm.
supports. But
Yeah.
um, that's not the norm in this population. So we at least want to make sure that they've got some grounding under them before doing any
Right.
directed trauma work. We also know, and this is significant, has come up recently, that for some survivors, they may not have to do trauma work. It may
Mm.
be enough for them to do relational work and this what's called present-centered treatment.
Hmm.
And if they're still symptomatic, then you move into doing the trauma work, um, emotionally. But
Hmm.
it may be enough to do it in a cognitive fashion, just talking about it in a narrative fashion, and not going into what are called evidence-based trauma focused treatments.
I'm glad you brought up the issue, and I'm glad it's being addressed in the book, because even in the EMDR community, which is my primary modality, this debate is raging over how much preparation do you really need, and some influential figures have really kind of railed against it. And I bristle when I hear that kind of disregard. And yeah, and I totally agree with your idea that it's not one size fits all, and you do have to feel it out client to client. And in my experience, some clients do need, it needs to be a progressive trauma processing or trauma work maybe before they can really get, and I don't like the word stabilization. I like preparation, because I think a lot of clinicians set themselves up to fail with stabilization. They think, well, the client's not stable, I can't do the trauma work. And I like to joke, there are some days I don't even feel stable. And it is very much
Right.
you have to feel it out. And I like this idea of it's not one size fits all.
Right.
So, and I know a question, go ahead.
I want to jump in here because I favor, and I agree with what you're saying about the misuse of the term stabilization, but I favor that term because some of these clients' lives are so chaotic and dysregulated and unsafe. So we can talk about safety, but stabilization to me means other things, helping them get their lives and their reactions back at a level where they can function. So I just wanted to make that, add that caveat.
That's an excellent point.
I like your preparation too.
Yeah, how are we defining stabilization? Because I think that's an important point of this. So yeah, a common question I get, and I'm curious how you take it on in the book, and you're not going to offend me with this answer, because I'm not a one size fits all person, even though I have my three main modalities I tend to use, and I dabble in some others. But there's this idea of, well, what works best for complex trauma? Is it brain spotting? Is it EMDR? Is it somatic experiencing? Is it CBT? Is it the new flavor of the month treatment? And when you're asked that question directly, or maybe how it's handled in the book, what do you tend to guide?
Well, and when we're open also to evidence and to the evidence-based treatments, and I think where there's evidence that something has effectiveness as a treatment, that it's important to know that and to incorporate it. But again, it's not one size fits all. I've been writing about that since 1999.
Good.
It is something that needs to be formulated with the client, and we have all of these different methods that can be applied. So the issue, I think, is, are you getting the work done? Are you allowing them to either restabilize their lives and not be symptomatic? So that might be present-centered therapy. And I'll put a plug in for Steve Gold here, who I mentioned earlier. Steve just updated his book on contextual trauma, and now it's called the Contextual Treatment of Complex Trauma. And his work is almost exclusively focused on skill building in college students. And he's found really good data to support that, because his patients have come in and said, we don't know what normal 101 is. We don't know how to do these things, how to function. And so he paid attention to that, and as a treatment that is provided in that particular therapy. It doesn't mean trauma is never addressed. It's talked about, and it's talked about in terms of its effect, but it's not a treatment that goes into trauma processing in the way that other treatments would. So I think it's very much an individualized process, and I think we're coming more and more to that as we do a comprehensive assessment and we start the treatment, that we really talk to clients about what's available and how we typically do it and what we would recommend. And I think the therapist has to maintain some authority about what's recommended. For example, I had a client who once came in at the start of, after doing an assessment, and he was very complicated and very dissociative. He said to me his goal was that we had to use methods that I was going to tell him his incest memories. Well, that was not a goal I could agree with. There's no way I can tell him what happened to him as a child. And I disagreed, and I said, if that's what you're going to do, I'm not the person to work with, which gave him a conniption, because he thought that I knew everything about incest. And he had some other very serious life issues going on, and I said, I will work with you so we can stabilize these life issues. And he grumbled for a year. And after a year, he said, I guess it was good that we did this.
Yeah.
Because I'm in a much
Yeah.
better place to begin to address whether I was incested in these ways.
Yeah. Thank you for bringing that up. That same question came up in my consultation group last night. So I was kind of smiling with some recognition.
Oh,
How do you deal with it when a client asks
Yeah.
for that? So kind of as we're wrapping up our time together, while I have your ear, we're in some interesting times right now with both COVID and with everything that is happening with the call for racial justice and racial equality. And it's very interesting to me, you got into the field in the 70s at just as the first civil rights movement was really having its impact. So, I mean, just anything you want to share about what you have learned historically and how it's affecting how you're seeing what's happening now, and maybe what we need to do going forward.
Well, what you just brought up for me was a memory. The work that I had to do at the time in the residence halls when I started working there was racial equality work. Actually, a program had been put together at Maryland because, believe it or not, only in '71 had the university was desegregating.
Yeah.
And so I saw a lot of that firsthand at the time. You know, I think these things happen in cycles, and you know, Me Too happens in cycle. It's happened in a cycle. I think it's been for those of us that have been in the field for rape crisis for 40 years or 50 years. You know, it's been very frustrating to see the limited amount of progress that's been made. But Me Too has, you know, captured our time, and I fully expect that there's going to be a backlash, and one has already started. But you know, I think that we make this progress incrementally, and the more information we can get out there. Like I heard a congressman talking about the role of trauma this morning on, you know, minority, Black and brown populations, and I was like, yes, finally. And I know, you know, some of the organizations that are doing that work and educating Congress people. So, you know, I think we just have to keep on plugging, but realize one of the big things I learned is always going to be a backlash. Don't expect everybody's going to agree with us, and we have to just keep doing our thing.
Thank you for that encouragement. And again, thank you for chatting with me today. Thank you for your endorsement on the second edition of Trauma and the 12 Steps, which is coming out here next month.
Oh, good.
And again, can you hold up your book cover so we can shout it out one more time?
Okay, I can. And also, Jamie, I really want, whoops.
Hold it up in front of you. So this is Treating Complex Traumatic Stress Disorder in Adults. And it's now out and can be purchased wherever books are sold, the second edition.
Yep. I also want to endorse your Trauma and the 12 Steps because there was so much, and that's another place where information has been so lacking, and you did a beautiful job integrating those issues, which I really appreciate and endorse.
Well, that's my passion, and I'm grateful to our friend and colleague Rob Weiss for putting us in touch, since he also shares that passion with me. And thank you for taking some time to speak with me today. I know a lot of people that I train and who follow my work will just appreciate this very good overview. And for people who may not be clinicians, I know that this is also a very interesting topic of how trauma can take on different forms, that that even how it manifests is not one size fits all. And
absolutely.
The long criticism I've given of the traditional PTSD diagnosis is, I think it was a good start for the time, but it was very and is very event centric, like this one thing that happened to qualify for the symptoms. Whereas I think where the complex trauma, the developmental trauma movement has taken us to is that trauma could be a day in, day out experience. And even if you are traumatized once or there's one event, there's usually fallout. So it tends to be more of an experience than an event.
Yep. I agree with that.
Great. Well, once again, Dr. Chris, thank you so much for joining us today.
Okay, thank you.